Hello, my name is Dr. Sarah Haywood-Small, and I am a senior lecturer at Sheffield Hallam University. I have 20 years' experience of working in cancer research, and I'm also a very proud member of the British Society of Immunology. I would like to thank CLL Support today, a very important patient-led charity. Today, I have the opportunity to speak to you all to highlight, in simple terms, some of the very recent developments that have occurred within the scientific field in relation to COVID-19 and, of course, with blood cancer. Now, ever since the coronavirus pandemic brought the world to a standstill back in March 2020, there's been talk of a vaccine, and it has been in the headlines. In this talk, I want to talk to you about the British Society for Immunology, and I'll highlight some of the resources that we have. COVID-19 vaccines have been badged as our biggest opportunity to control the virus and return to normal. And there's more than 300 vaccines in development and there's been 3 that's been rolled out across the UK. At the BSI, we want to make sure everybody has the information about the COVID-19 vaccine. And what I want to do today is to talk about some of the emerging messages that are coming out of the very latest research findings about the effectiveness of these vaccines in relation to cancer patients. A lot of what I will talk about is blood cancer in general, but this is also applicable to CLL patients. I want to talk about, well, where do we stand today and what does this really mean for me as we move forward over the coming weeks and months? So I am a very proud member of the British Society for Immunology. The BSI is one of the oldest and largest, indeed the most active immunology societies in the world. It's the largest in Europe. And today I hope my passion comes across in terms of engaging with the public. It's really important that we talk to you out there and to work with people in research and health environments. I've been a member of the BSI for many years, and we also put together a series of public information links, and you can see here some links on screen. And indeed, one of my personal passions is to really bring this to life, really, using a series of animations. The immune system is very complex. I think of this in terms of a family. It's a population. All the different cell types have their own personalities, their own jobs, and the whole system is a really intricate network. Also, you get communication between cell populations as well, and this can change on a day-to-day basis. And I think this key understanding really underpins some of the latest research that we know with respect to COVID-19 and blood cancers. I think of the immune system as a family. It's very intricate. It's got a bit of a hierarchy. And it's important to realise that the immune system is derived from bone marrow, which most people will have heard about, that you can find bone marrow in our long bones, such as the bones in our legs, okay, the femur. And all cells will come from a very early cell, which we call a stem cell, okay, a stem cell. HSC stands for hematopoietic, which means blood stem cell. It's a blood stem cell at the top here. And these stem cells, almost think of these as the kings, okay, kings. And these can change, they can evolve into many different types that serve underneath them. Okay, so we've got the stem cell up here. And when it says multipotential, as the name suggests, it means that it can go on to do many different things as well. But like the immune system, it gets divided into 2 main categories, which you may have heard of. We've got the lymphoid cells and we've got the myeloid. This is essentially 2 branches of the same team. Okay, 2 branches. So the first team is the lymphoid cells as well. And we have a number of cells. We have 3 different cell types that are part of this lymphoid team. And you may hear about these in various different meetings, on the television in recent months as well. We have natural killer cells. Natural killer cells, these are almost like the tanks of the immune system. Okay, so they are part of the immune system that we are born with. These natural killer cells are like tanks. They move very slowly through the body, and these seek out and destroy anything that they see to be a threat. Okay, so it can be, for example, a virally infected cell, it can be a cancer cell. These natural killer cells, they literally release chemicals. It's like chemical warfare, and they destroy cells that need to be destroyed, abnormal cells. Now, 2 of my main cell types that are my personal favourites are the B cells and the T cells that you might have heard before. B cells get their name from the bone marrow. T cells get their name because they learn how to be a T cell from the thymus gland. Okay, and with the B cells and T cells, these cells stand apart from all the other types of cells because the T cells and B cells have memory. They have the ability to remember, maybe up to 20 years, they have the ability to remember things. And the beauty of that is that when you come back to them, for example, and the same viral infection, the T cell remembers very quickly, and it can clone itself and it can attack that virus, for example. So T cells and B cells are part of what we call our adaptive immune system that develops after birth. And with the B cells and T cells, these spring into action. B cells produce antibodies, B cells antibodies, and T cells are cell-mediated immune reactions, which means it's basically cell onto cell fighting. So the cells will release toxic chemicals that will destroy any cells, for example, that have got abnormalities in them. So the B cells and T cells are part of the adaptive immune system. So the B, the T, and the natural killer cells are all part of the lymphoid lineage. Okay, so they're part of one team as well. But the stem cell can also turn into what we call a myeloid stem cell as well. And you can see there's a number of other cells that come off the myeloid branch. Okay, all of these cells are fairly non-specific. They're not associated with memory. Okay, you might recognize red blood cells that carry oxygen around the body, really important. Platelets, these are small entities that are involved with blood clotting. And then we have what we call phagocytic cells that are like Pac-Mans. Yep, they're like little Pac-Mans, phagocytic cells. And we have here monocytes. These grow up into what we call macrophages and neutrophils. And these are phagocytic cells, which they're like police dogs. They chase any invaders. They chase them down, literally. They move around, they chase them down, and they actually eat them. That's where the word comes from. Phagocytes. Phagocytosis, it actually eats the offenders. And then we have other rarer cells such as the basophils and eosinophils, and some of these specific cells are involved with unique interactions, such, for example, infection with a parasite. You'll see a lot of eosinophils as well. So these are all the different types of the immune cells. So they have their own personalities and all the different types of jobs. So some of the emerging messages that have come across in the last few months. I am sure you're aware through discussions with your clinical teams about the fact that cancer can really increase the risk of severe illness from COVID-19 infections as well. Not only that, but in blood cancer, there is an even higher risk compared to people with solid cancers such as breast and lung cancer as well. And we need more studies to really look at the risk factors really and help people manage treatment for people with cancer and COVID-19. Many people now have had one dose, if not both doses of the vaccine. Uptake is fairly high, and that is very pleasing to me. Several vaccines are now available, and indeed, it is really important to say that experts still recommend, of course, that everyone who is eligible to get vaccinated, as long as there are no contraindications, things like a history of severe allergic reaction, for example. But the vast majority of people have been invited and indeed have come forward, which is great news as well. There has been a lot of data recently published with respect to cancer treatment, how it can suppress the immune system as well, especially with certain patient groups. So, for example, we understand that neither the Pfizer vaccine nor the Oxford vaccine is tested in immunocompromised patients. But the current advice for people affected with CLL is that they still should have the vaccination. About 40% of the people vaccinated in the Pfizer trial were over 55, and it's thought, well, it really works well in this population. It's important to speak to your clinical team if you've had recent treatment, such as chemotherapy, stem cell or bone marrow transplants as well, to make sure that your immune system, your cells, have a chance to recover so that they can fully perform their role when it comes to an active vaccination. It is important to also remember that the clinical trials have shown that the safety and the efficacy of vaccines are similar in people with underlying conditions and in people without those conditions. Recently, some reports have emerged in March and April that I will highlight, which suggest that we need to look at this very closely. The bottom line is that most COVID-19 trials have excluded people with cancer. So therefore, as scientists, we have very limited data sets about these individuals as well. And it is very important, especially now most people have taken up the invitation to have the vaccine, that people should follow all current guidance to protect themselves against others, against COVID-19 exposure. Vaccination is only one aspect to keep us all protected. So vaccines are still being offered to people that are now at high risk as well, and this will be crucial to actually save lives. In terms of the recent research, it has been a very busy few months at the time of this recording. Back on the 11th of March, there was some initial data that suggests that one dose of the Pfizer vaccine was less effective with people with cancer. Now, please note one thing. The research needs independent review by other scientists. So it is really important that this information is reviewed by more scientists. However, this study was picked up by the BBC News and other people as well. So you might have heard about this as well. It was the SOAP study, which involved 205 volunteers. And this looked at patients with breast and lung cancers, so solid cancers, and also with blood cancers as well. Individuals that had received immunosuppressive treatment. And researchers found a different level of antibodies. Now, we would expect this in terms of the immune profile, because a lot of these patients have the difficulties in making an effective immune response. So when we looked at the antibodies, now an antibody is simply, it's almost like a little target, a small protein that is produced by the immune system under certain conditions. And this protein, it almost is like an X marks the spot. So it actually highlights something that is important for the immune system to target and destroy. So often we produce antibodies in response to viruses, in response to bacteria. So by measuring antibodies, and these can be measured in the blood, indeed a lot of antibody measurements can really show you how healthy you are in terms of your immune system, the different cells and the profile. And this study showed the antibody response at about 3 weeks following the first dose of the vaccine. And you can see, compared to the group without cancer, only 13% of the group with blood cancers had an antibody response as well. And this information was kind of picked up by the BBC. And there is a quote here from Professor Adrian Hayday as well. And it's interesting to note that he says that one of the key features is the time interval between the first and the second dose. Researchers showed that the gap of 12 weeks could potentially leave people very vulnerable to severe COVID-19 as well. So when looking at the results, there's some important things to take into consideration. We're only looking at one of the vaccines here as well. Many of the participants were often in an older age group as well, and these are other factors that are on top of the fact that they also had blood cancer, for example. And there are other studies, such as the uptake studies, which are also ongoing about looking at how vaccines really work in specific individuals. So it is really important that we diversify this research to really understand the diverse clinical groups. Towards the end of March, it was on the 26th of March, we then got the critical care report from the Intensive Care National Audit and Research Centre. Again, this was picked up by a few cancer charities, and again in the headlines as well, which showed there is a rise in the proportion of new admissions of blood cancer, according to their analysis as well. And I've taken a table directly from their report, and you can see that compared up to 31st of August last year, there is an increase we have seen from the 1st of September 2020 here. And this is data from patients that are critically ill with confirmed COVID-19. Despite this, the risk of people with blood cancer becoming seriously ill with COVID is now much lower than it was, for example, 2 months ago. It's important to take this within context because we have a lower infection rate at the moment because of the number of people contracting it as well. But it's still something to think about for these high-risk groups because we have some concerns that people with blood cancer have weakened immune systems. Their immune cells cannot do their job sometimes. So it's therefore plausible that vaccines tend to work less well. So we need to look at this very carefully. What the report does say when you look through the data is between September of last year, September 2020, and it was the end of February, about 1 in 68 people admitted to intensive care with COVID had blood cancer, but then from March the 12th to March the 25th of this year, this increased to more than 1 in 20. So what it's saying is that that you have this increase as well. Having said that, people, the risk of people with blood cancer becoming seriously ill is much lower because of the lower infection rate in respect to the general population. I think in terms of a number of charities have picked up on this, and the concern is really that the number of people with blood cancer are accounting for a higher proportion of intensive care admissions. That's one of the main findings of this report. It could be a sign that the vaccine is not working as well for them compared to other high-risk groups. As with all vaccines, vaccines are never 100% perfect, and indeed there's always a risk versus benefit conversation to be had in all cases. But I just wanted to show how very fast moving this field is, because you can see there is a number of kind of questions that have been put forward in Parliament with respect to the coronavirus vaccination questions in the Department of Health and Social Care, shown here on the left. This question was shown on the 14th of April 2021, and on the right here actually is the Shadow Health Secretary John Ashworth in a letter to Matt Hancock, and following the results with respect to the first and the second dose, time duration, with particular interest of blood cancers, this letter is urging Matt Hancock to provide greater support to the blood cancer community. So indeed, you can see how it's a combination of political enforcement plus the scientific facts that are really working together with patient groups. So it's a really important time for everybody. The most recent information was just published over a week ago at the time of recording in April, and this was in a very good journal that is quite prestigious, the Lancet Hematology, and it found that the first dose of a COVID-19 vaccine triggers an immune response in about 70% of patients with myeloma, for example. Okay, and these patients had either had the Oxford or the Pfizer vaccine as well. So this work came out of the Institute of Cancer Research in London and the Royal Marsden NHS Foundation Trust as well. And this was a study in myeloma, and 93 people were involved. The results didn't follow up with the second dose, so we will hopefully see those results over the next 6 months. So where do we stand today? Well, both studies have only looked at blood samples from a small number of people with cancer. So we have to look at all different types of cancer. Indeed, we need to look at these patients over time as well. And we are waiting more evidence on this. So it's important to really keep up to date through charities, through public awareness activities like this to make sure you get the information that is in the right place. It is a very complex situation as well. For every person, it is different, and everybody is a unique individual. It will depend on the cancer type. It will depend on the treatment that you've had, the timing in relation to vaccination, on top of many non-cancer related factors as well. It's important to really put people's mind at rest that there's no reason to suspect that one vaccine is better than another one. And with my hand on heart, I would say that any protection provided by a vaccine is better than no protection. Okay. Remember that the immune system is made up of different cell types and different cell personalities. So indeed, we need to learn more about these intricate networks, these communication pathways to really make sure that we have the best protection for every individual patient as well. And of course, if you've got any concerns, please speak to your specialist or your GP about this to keep up to date with the latest developments. It's likely that more people will be invited for boosters, and we have to work out exactly how often these need to be administered. And we can measure this. We can measure the efficiency of your immune system and how it's reacting through a series of antibody tests in your blood. Remember, antibodies are almost like little targets that can be produced by the immune system as well. There's different types of antibodies, again, and these antibodies can be really useful to give us some degree of effectiveness. And so we need more data on these COVID-19 vaccines. We need to look at more studies with respect to antibody production as well. And this will really inform practice. I hope that this message has come across today as well. It is a very fast-moving area as well. And remember that it's a personal choice, and it's important to emphasize the risks of infection and the benefits of vaccination very clearly. For me, as a scientist, it's really important that I ask the right questions. Often that is more important than the answers. So many people are very vulnerable in this year with respect to COVID-19, and getting a vaccine will mean that it is a step forward in terms of protection. We need more diversity of participants in these vaccination trials, and over the next 6 months, we will really get some firm data on all of these patient groups. This will take time. Okay. In terms of a vaccination, does it give you 100% protection? The answer is definitely not. Okay, in general, the older you are, the longer it will take as well. And it is important to always make sure that CLL patients are involved in the discussions with government, with pharmaceutical industries and other charities as well. So we can really build up a picture to ultimately understand how much protection you will get from the vaccines. There's also indirect measures as well in terms of government policy about the benefits of offering vaccinations to caregivers of cancer patients. If infection rates fall, then it is less likely that you will come across that. So indeed, that will help as well. So it's a combined effort on all sides. It's quite poignant actually when you read about all this information really, and you do feel as though that the initial dust is settling with respect to the pandemic. The vaccine rollout is a great success program, especially in the United Kingdom. But now we need to refine this ultimately for patient groups, and I'm a great believer in this really, because we need to look at this. I think historically it's been true as well, because often immunotherapy used to have a bad press in the past, you know, if we go back a few years, and it's only until we start to appreciate the diversity of the immune system, the different cell types, we can really unpick which cells will be more beneficial or more detrimental. And it's this balance. We do this all the time with relation to transplant immunology, for example, bone marrow transplants, you know, graft versus leukemia effect and things like that. So we need to understand the intricate cell populations. I believe that understanding this will ultimately be the main tool to help protect people.